disclosures. Our institution received funding for research from a few companies, Epimed, Infutronics, Teleflex, Myosciences, and SPR Therapeutics. I myself have served on medical advisory boards such as Avanos and Heron Therapeutics, but none of these things we're going to be talking about today. The outline of our debate is first, we're going to talk about opioids in the perioperative space, the pros and cons, and then go into thoracic epidurals versus other modalities, and then go into multimodal analgesia pathways, the pros and cons of that, and we'll conclude with a summary of acute pain services and ERAS pathways. So the opioid epidemic, over the past 10 years, we've been seeing a huge spike in opioid overdose. It's actually the third most widely prescribed drug in the US, hydrocodone being the number one. We use, as a country, 80% of the world's opioids, but there's no evidence that we actually even have any better pain outcomes. And then, as you could see, that over the last, since 1999 to 2011 or so, there was just a slow increase in opioid overdose related deaths. The green line marks any opioid. And then you can see from 11 to 17, it really spiked up. And then this graph shows the difference between males and females. You see that the males, which is the gray line, has always had an increase in death compared to females, but that they both rates increased significantly over the last 10 years. So where are these opioids coming from? Why are patients getting, or are people getting a hold of all these opioids, and especially over the last 10 years? This pie graph shows the breakdown of where the source is most of the time. So you can see that the blue piece on the left, that represents opioids via a prescription, or if it's stolen from a healthcare provider. But then you can see that the majority, which is on the right side, more than 50%, most opioids are given by, brought from, or took from a friend or relative. So it was diverted in some sense. And then a smaller portion, the maroon, is the ones that are from drug dealers or strangers. And so we see the biggest problems is from prescribing, and those opioids that are prescribed or are diverted to friends, or if they're left, usually some patients might have leftovers and then they're used for other reasons. So that's where a lot of these opioids are coming from. So that leads us to our topic, how we've been responding to the opioid epidemic in terms of in the perioperative space. And to start this off, I want to point out to a nice editorial that was written in Anesthesiology that summarizes how anesthesiologists have been responding to this opioid epidemic. This epidemic, it's caused an opioid phobia. I think now everyone is developing protocols and designing studies and doing everything they can to really avoid opioids because of this opioid epidemic. But we forget to realize what gave rise to the opioid epidemic in the first place, and that was poorly managed pain. And we still have surgical pain is still managed poorly. And to move, now we're moving away from opioids, which have been shown to decrease pain, to other modalities that may or may not have been shown to be as effective through studies. And worst of all, if we don't manage acute postoperative pain, that can lead to chronic pain. And we found, there's a lot of studies that have been showing that the real problem has been with perioperative, has not been with perioperative use. It's been the outpatient and discharge opioid prescribing. Much of what I showed you in that pie chart, that's where a lot of the opioids were coming from. It's not necessarily what was happening in the perioperative space. So then why are we, as anesthesiologists, how many of us are touting opioid-free anesthesia. You know, many people say it provides superior anesthetic outcomes and risks and reduces the risk of chronic opioid use, but there's no clinical trials proving this. In fact, there's one study that I'll show here that developed a opioid-free anesthetic protocol for colorectal surgeries. It was a prospective study comparing to historical controls. And the box on the right shows the protocol that they followed. The yellow portion of it, which is the larger middle of this box, is describing their opioid-free and multimodal analgesic protocol. And you know, their pathway consists of epidurals, regional anesthesia, ketamine infusions, lidocaine infusions, and basically avoiding opioids altogether. Although if needed, opioid was available, but sort of as a last resort. When they did this, on the left side, you can see on the left graph, that shows how much intraoperative milliequivalents of morphine was given the pre-ERAS, the pre-protocol period. You can see that the opioid use was larger. And when they implemented this pathway, it was, they used less opioids. However, on the right graph, you can see that there was no, this is how much opioids were prescribed at discharge. There was essentially no difference despite using less opioids in the ERAS group. In fact, there was a study published in 2020 or this year that showed that opioids themselves can be opioid sparing. In patients that were getting complex spine or cardiac surgery, patients were randomized to either receive methadone or no methadone. And then if you compared both of these groups, on the left side is frequency of post-surgical pain in the non-methadone and the methadone group. And then if you see there's some statistical significance in the first a couple months in the methadone group, which goes to show, using opioids can actually can be opioid sparing. So when we think about, do we need to abandon opioids altogether? Much of what people are touting about, this opioid-free anesthesia in response to the opioid epidemic, the truth is there's just not enough evidence to say that we need to abandon opioids altogether perioperatively. Not enough evidence that we need to decrease it intraoperatively or even in the acute postoperative period. We need to, as suggested by the editorial by Karash that I mentioned, we need to approach perioperative pain less arbitrarily and more evidence-based. Focus on what is known to be problematic. And again, what is known to be problematic is opioid prescribing as an outpatient. And to really, understand whether we need to reduce opioids or do opioid-free anesthesia, we need more large-scale, high-quality studies. So I am going to switch the mic over to Dr. Saeed, and she'll talk about the cons of, or why we should reduce opioids.
Good morning, everyone, or good evening, Trisam. When we talk about opioids, first, when we talk about the foundation of general anesthesia, there's three components. It's achieving a level of unconsciousness, immobility in the operating room, as well as good autonomic control of all the vitals. And this is essentially what has defined adequate anesthesia. When you use a single agent, whether it's an inhaled anesthetic or propofol, you are able to achieve unconsciousness and immobility, but the autonomics become more difficult to control. You have to increase these concentrations of propofol or the inhaled anesthetic significantly to be able to have tight control of the vital signs. And this is essentially where the concept of balanced anesthesia came from. It's how to adding another agent so that we can achieve better control of the vitals intraoperatively. And so opioids are usually the most common mode that is used, and the benefit of it is it also helps with postoperative pain. Other agents that are used, you can use esmolol or adenosine, but they've essentially fallen out of favor, mostly because they don't have the benefit of postoperative pain control, just like opioids do, and then you need another infusion setup, and so most people veer away from them. So the addition of opioids has had synergistic effect to achieve general anesthesia and this balanced anesthetic concept. But with the therapeutic benefit of pain control comes also some adverse events, some of which, we touched upon earlier with the whole opioid epidemic. But we're also, when I say adverse events, there's the immediate postoperative nausea and vomiting, the respiratory depression, with more as you increase those doses. But more than that, we want to talk about long-term effects that the opioids have. Again, we touched upon this with the opioid epidemic, that 2 million Americans are still dependent on opioids, and more than 4 million of them use these prescription opioids non-medically. Where does it start? And the majority of it comes from prescription of that are written in the for acute postoperative pain, whether it's inpatient or in ambulatory care. And the reality is, that we overprescribe, and what happens to those opioids, they're stored somewhere in the house. And like Dr. Gabriel mentioned earlier, there's concerns for diversion or so. But even short-term opioid uses can have long-term consequences. So if we look at this study looked at risk of prolonged opioid usage among opioid naive patients. So these patients on the blue side, you see preoperatively, they've taken no opioids at all. The higher their opioid consumption in the perioperative period and during their inpatient stay, the more likely they are to report higher use of opioids after discharge. And also these patients who leave the hospital with huge amounts of opioid prescriptions are also increased likelihood to become long-term opioid users. So we do have a responsibility in the perioperative setting to set them up for future success outside of the hospital. And what is persistent opioid use after surgery? There's a couple of definitions. Some, will say it's if you're using opioids for longer than 180 days, or people who use it at least once a day for about a year, or some people calculate it based on oral morphine requirements daily. But regardless of the definition, this study looked at about 390,000 opioid naive patients who went into, and then who had minor surgeries, including cataract and laparoscopic cholecystectomies and TURP procedures. These patients who were discharged with an opioid prescription within 7 days of surgery were 44% more likely to become long-term opioid users. And 10% of those actually continued to use their opioids for more than a year. I don't know why anyone having a cataract surgery needs an opioid prescription at all, but it does have an impact long-term. And the same, they actually looked at even just NSAIDs. If after cataract surgery, you send the patient home with NSAIDs, that same amount, about less than 10% of them will continue to use these NSAIDs for a year afterwards. And then in this study, they looked at the characteristics of that initial prescription that you write when you're sending the patient home after surgery. So they looked at the number of days, and these are all, again, opioid naive patients, the number of days that the prescription is written for. There was a sharp increase around day 5 and day 31. So for every extra day that you prescribe opioids, there's an increased 1 year and 3 year probability that they'll still continue to use those opioids. They also looked at, the number of prescription refills that were done, and same thing, the more prescription refills the patient had, the more likely they were to become chronic opioid users. And then I also wanted to talk about the concept of opioid-induced hyperalgesia, and this acute opioid tolerance. And, we talk about in the perioperative period, does it really matter if, I give so much opioids in the OR? Do you really think it impacts the patient in the short term or the long term? And in this study, this is also a randomized controlled trial where they randomized patients to introp Remy, running at about 0.3 mics per kilo per minute for about 3 hours. Sorry. This was about 50 patients that they randomized to either have 0.1 mics per kilo per hour of remifentanil and then titrate their anesthetic of desflurane up for the autonomic response, versus the second group where they maintained half a mac of desflurane and adjusted their remifentanil dose based on patient's response to surgical stimulus. Both groups had morphine, and they found that patients who had the increased exposure to remifentanil in the OR did have had higher pain scores in the PACU, as well as higher morphine requirements. And this was another similar study. They said, well, how much exposure? Basically, the question was, how much Remi do you need to really induce that acute tolerance? And in this study, they randomized children who were undergoing laparoscopic surgery, and they found that the patients who were getting lower doses of remifentanil, around 0.3, had no difference, versus the ones at higher doses did show signs of increased opioid requirements and increased pain scores in the PACU, and those doses were around 0.6 to 0.9 mics per kilo per minute. Opposite of that is this study that was published in ANA in 2007. They actually had 3 different groups. They had a control group, an esmolol infusion group, and a remifentanil group. And in this case, remifentanil was a continuous infusion that was titrated between 0.1 to 0.5 mics per kilo per minute. And if you look at the table here, the amount of fentanyl that was used in the PACU with the esmolol group was significantly lower. It was actually the lowest compared to the control group and the remifentanil group, as well as, the need for ondansetron, and the esmolol group was the lowest, and the number of events of nausea in the recovery room was also the lowest. So we brought up the point of, opioid-free anesthesia does not necessarily have an impact or change in the opioid prescription at discharge. And this is the same study that Dr. Gabriel actually referred to. And, it just doesn't make sense to me that, how is it that if our patients, in the OR and in the PACU require minimal to no opioids and they're on the floor, then how is it that it doesn't impact discharge opioid prescription practices? And I think it really comes down to education. If you look at that same paper, they talk about that 70% of those patients who had these prescriptions, they had low discharge pain scores. Some of them, all of them were had no preoperative opioid use, and 70% of them had low morphine requirements while they were in-house. So we need to modify our opioid prescribing practices. And I think for this to actually influence, for opioid-free anesthesia and all these multimodal and ERAS protocols to have an impact on this opioid epidemic that we talk about so much, we need to actually change our practice and develop more patient-centered care and look at how much they required. I think we, at UCSD, we also saw this, the acute pain service started managing, taking care of the pain management for our ortho joint patients. And we decreased their opioid requirements significantly, close to 60 or 70%. But then 6 months later, we realized that the nurse practitioners and the residents were still sending them home with 80 pills of oxycodone. This is the same patient who had a hip replacement, and while they stayed 2 days in house, they only took 2.5 milligrams of oxycodone, is now going home with 80 pills. So we did some education there, and that's definitely now reflected of what is going on. So really, what I think we need to do is just do a lot more education with post-discharge opioid prescription practices and look at the patient and set our goals and also set really expectations. You know, patients are scared that they're going to be in uncontrolled pain at home, and to have close follow-up and, you know, not give prescription for so many days, because it sets them up. It sets them up to believe that they should expect to have pain for a prolonged period of time. So there's something to say about the mindset and setting expectations with the patients also. Next, does anybody have questions about this before we go on to our next? Or should we just keep going? We'll keep going.
So Dr. Say, just go ahead and keep going, and we'll save the questions for after.
All right, so one of the next topics that we were going to discuss is thoracic epidural analgesia, which falls under, it's one of the modalities that we use to achieve this opioid-sparing effect. And, you know, thoracic epidurals, they've been around for a long time. They, you know, continue to be one of our more challenging procedures for anesthesia. And time consuming, but I still think that they add so much value and continue to be recommended for certain procedures. And we'll talk about that. Just, you know, briefly, some of the described benefits of thoracic epidurals is that, you know, it provides superior perioperative analgesia compared to opioids alone. There's decreased pulmonary and cardiovascular complications, especially when their infusions are running intraoperatively, and it has to do probably with the more autonomic stability. And then they've decreased the duration of postoperative ileus, and whether that's because of the sympathectomy that's achieved or, you know, the secondary effect of lowering opioid requirement is still unclear. But and they've also been shown to decrease mortality in patients with rib fractures. There's different types, there's multiple options of infusions that we can run, whether it's local anesthetic or local anesthetic with opioid combination. You know, each has advantages and disadvantages, but I think an experienced practitioner could really optimize these solutions to achieve their goals. For enhanced recovery, you know, this is publication in the World Journal of Surgery, guidelines for colorectal surgery. They describe thoracic epidural analgesia as the gold standard for patients who are undergoing major abdominal surgery, and that it's superior to systemic opioids. Similarly, for clinical practice guidelines, also for ERAS and colorectal surgery, that thoracic epidural analgesia still remains the gold standard for open procedures, but not necessarily for laparoscopic cases. In this paper, in anesthesiology, it was a randomized controlled trial, also for colorectal patients. They had about 50 patients, and they randomized them to epidural analgesia versus a continuous preperitoneal analgesic, and they found that the length of stay for the epidural group was decreased, but not only that, these patients with the epidural, they were able to resume full diet sooner. They had earlier return of bowel function, their sleep quality was better, and their overall postoperative complications were also lower. Similarly, in the American Journal of Surgery, they compared incision wound catheters to continuous epidural analgesia, and they did a randomized controlled trial. They were able to show that epidural analgesia is superior to just opioids alone for colorectal surgery. Secondary outcomes like return to bowel function or length of stay were not affected. And then, you know, in this surgical journal back in 2014, they showed that actually thoracic epidural analgesia has a positive impact on mortality and morbidity after surgery. Not only did it reduce mortality, but it also had decreased risks of cardiovascular, respiratory, and GI complications. So if the surgeons are still on board and think it's gold standard, I don't see how. I agree with them that epidurals can save lives.
All right, so I think a lot of things that Dr. Saeed mentioned, it shows that, so if epidurals are so great, why aren't everyone doing them? Why are some surgeons against the idea? And so I think it's important that we also talk about the cons of thoracic epidurals in the setting of opioid reduction. It's not moving. Okay. So there are a lot of downsides with thoracic epidurals. I'm sure a lot of you are aware. They're not without its side effects. I think a big one is the hemodynamics of it. It causes a lot of hypotension and bradycardia, and especially in the setting of patients that are getting big abdominal surgeries with a lot of fluid shifts, a lot of blood loss. This hypotension is something that, we have to take seriously. So a lot of times what ends up happening is you may not be able to use the full effect of the epidural, because the higher you go on the local anesthetic dose, the more it has an issue with the blood pressure. And so this can cause some issues. There might be some more urinary retention, which can cause a prolonged bladder catheterization, which can increase risk of UTIs and hospital length of stay. There's been a number of mainly retrospective studies that have been showing that the use of epidurals can prolong hospital length of stay. And in addition, epidurals can cause some motor impairments. You get some very rare risk of infections and hematoma as well. So, it's not without its risk. And furthermore, it can be for some, in some institutions and some practitioners, it can be difficult to place. And in some patients, it could be really difficult to place no matter who's doing it. And then you also require extra clinical resources, someone to follow the epidural every day to make sure it's managed correctly. So it's not something you can just put in and expect it to be perfect every time. So there are alternatives. And people, some practices are using these alternatives, things like tap blocks, erector spinae blocks, surgical site infiltration, which Dr. Saeed mentioned in one of the studies, and even liposomal bupivacaine. If we look at a study that looked at continuous tap blocks, they found that actually when you're doing laparoscopic colorectal cancer surgery, that they show some benefit over epidurals. This study looked at 3 different groups. They looked at a control group that had neither of these options, a TAP group and an epidural group. Each group had about 60 patients. And they essentially found that patients that were in the TAP group had shorter length of stay versus the epidural group. And part of the reasons is patients had the urinary catheter removed sooner in the TAP group. So this is one of the downsides that I mentioned that are potentially related to epidurals, is urinary retention. And then the TAP group just had some less sensory disturbance, not as big of an issue, but it is something that may make some patients feel uncomfortable. And then another study, they looked at continuous surgical site analgesia. So during, before closure of surgery, they put in the catheters in the wound. The surgeons do that, and then they just run local anesthetic through that. And they found that, there are some benefits over epidurals when they did it in open nephrectomy. This one, it was, they also had 3 groups, a control group with neither of these pain interventions, and then an epidural group, and then a continuous wound infiltration group. What they found was, yes, the pain scores were oftentimes better in the epidural group than the continuous surgical site analgesia group, but it was comparable. But if you look at opioid consumption, it was similar up to 72 hours. What was interesting wasn't a primary outcome. They did find that peri-incisional pain and overall pain was actually decreased in the continuous surgical site analgesia group compared to the epidural group after 1 month. It's a little unclear why that's the case, but it's something that needs to be further investigated. But nonetheless, interesting to see this finding from this study. And then another study looked at continuous surgical site analgesia for open colorectal cancer surgery. This was published in ANA back in 2012. They looked at 2 groups. One was the wound infiltration group and the other was the epidural group, about 50 patients in each group. It was a multi-center study. And they found that after 48 hours, the pain scores in both groups were comparable. There was no difference in pain scores when coughing, and the pain scores were non-inferior in the continuous wound infiltration group to the epidural group at the 72-hour pain scores. They also found that time to first flatus and first stool was slightly earlier in the continuous wound infiltration cohort versus the epidural group. There was also less nausea and vomiting in the continuous wound infiltration group. So because we're seeing that, a lot of it is comparable, why not just go with the less riskier, less technically difficult option of continuous wound infiltration or TAP catheters versus the epidural group?
So I think while Dr. Gabriel raises very good points on why maybe we should not do thoracic epidurals, I think we have to talk about, it has to be, again, very patient centered. I don't think thoracic epidural is necessarily the best option for patients who are having laparoscopic procedures, but I do think for open abdominal procedures, they may be able to ambulate sooner and get out of bed and have less likelihood of having an ileus. But also when we look at these studies, thoracic epidurals, like we mentioned, they're very challenging procedures. And a lot of these studies don't show that they've actually confirmed that the thoracic epidural is actually in the epidural space. For us, we do our thoracic epidurals in the preoperative area. We give them a very generous dose we give the whole 6 mLs of 1.5% with epi, and before any patient goes to the OR, they have a level that spares at least 4 to 5 dermatomes that we can elicit with ice. Otherwise, that epidural comes out. A lot of these studies they don't, they just say we place the epidural. They don't talk about whether they confirmed sensory test or not. Epidural catheters thread really easily in all sorts of places, and we see that especially at an academic institution, all the possibilities, and especially if they're being done in the OR and the surgeon is hovering over you in the rush, you don't have time to check them. And I think also something that we see with these papers is, well, how are they managing these epidural infusions? I mean, if they're running them at very low concentrations, you might as well just turn it off. These very low concentrations help when the patients are lying still in bed, but when they start to move, they are not very helpful. And also, some studies say, hey, length of stay is prolonged with epidurals. Again, it falls down on who's managing these epidurals and timing, pulling them and converting the patients to a PO pain regimen. So next we'll talk about the multimodal analgesia, and in the general concept, is the use of non-opioid analgesics. And the idea is that, you use minimal doses of everything, then you prevent the adverse effects of opioids or any other medication by not escalating these doses. And the idea that comes with multimodal analgesia is that you'll facilitate enhanced recovery. You'll be able to meet those milestones a little bit earlier. There's early mobilization, return of bowel function. It's definitely a key component of any ERAS pathway. And practice guidelines for perioperative pain management now recommend that multimodal therapy should be standard of care for postoperative patients. Multimodal analgesia does not mean the total abandonment of intraoperative opioids. I think I think sometimes people see multimodal analgesia and automatically say, well, you must be like one of these opioid-free anti-opioid. It is not the purpose. The purpose is synergy, but together they will be better. We'll optimize both groups. Multimodal opioid-sparing analgesia has different components to it. So there's NSAIDs, there's glucocorticoids, there's acetaminophen around the clock, there's ketamine, magnesium, dexmedetomidine, clonidine, IV local anesthetic, and gabapentinoids, and as well as regional anesthesia and neuraxial anesthesia. In this study of anesthesiology, this was actually, they looked at over 1 million patients, I believe, who were joint replacements, who went for hip and knee replacements. And they looked at, if you look on the bottom of the graph, over the years, there's, we've really shifted towards multimodal analgesia. So they looked at groups of patients who've had opioids only, and then other groups have had either an additional mode, whether it's a peripheral nerve block or acetaminophen around the clock, or NSAIDs, or 2+ modes. So as you see, as the years have gone by, we've really shifted into this multimodal method of acute postoperative pain management. And with it also came down the opioid prescription, kind of what we talked about. But also they found that these patients who've had 2+ modes of multimodal analgesia, they've had fewer respiratory events and they had fewer GI events postoperatively. And same even in cardiac anesthesia, where we rely so much on opioids to maintain hemodynamic stability. In this study, they transitioned into having an enhanced recovery program for cardiac surgery, and they increased their interventions. They added ketamine infusions, Precedex infusions, acetaminophen, regional anesthesia, and gabapentin. And you see here, as the amount of opioids intraoperatively decreased, and the number of interventions is the amount of multimodal. There was no change at all in postoperative outcomes or intraoperative cardiac events. And I'll go back to you.
All right, so I think Dr. Saeed brought up a lot of good points about how medications, non-opioids, can work synergistically. And a lot of those medications have potentially shown some evidence-based benefits of reducing pain. So the purpose of these multimodal analgesia protocols is if we combine all these things in a protocol, are we going to actually make more differences? And so I just wanted to point out one study that was published this year in anesthesiology. It's probably one of the bigger studies and well-designed. It's from Cleveland Clinic, a multimodal analgesic regimen for spine surgery, a randomized placebo-controlled trial. They looked at 2 groups. One is the analgesic pathway, the other is the placebo pathway treatment, 150 per group. And then the analgesic pathway, they received intraoperative multimodal analgesia. This included, pregabalin, Tylenol, some ketamine, and lidocaine infusions. All of those infusions were then turned off. The ketamine was turned off at the end of surgery, and lidocaine was turned off at the end of the PACU stay. And then they compared it to the placebo group, which they had basically placebo versions of those medications. And then, so the purpose was to look at if these multimodal pathways in the intraoperative setting would have any efficacy in reducing opioid use postoperatively. And what they found was there's no difference. It was the non-inferior for 48-hour opioid consumption or pain scores. You know, and I think what the big point of this is that, you know, spine surgery is one of those, and I also want to point out they actually even looked at patients that were high risk for postoperative pain. So they looked at patients that potentially would benefit the most from multimodal analgesia. So this, you know, their study is showing that, okay, we combine all of these medications, non-opioids, to, you know, potentially reduce opioids. We do it intraoperatively, but turns out that postoperatively no difference were made in spine surgery.
So the anesthesiology paper that he cited, just wanted to comment that some patients received surgeon, some patients had an epidural catheter placed by the surgeon, and the authors did not control for that. And also they didn't control for any postoperative multimodal analgesics for those that were in the placebo group. So just wanted to point that out before we move on. One of the things that I wanted to talk about is what we have done here at UCSD. Our acute pain service was started back in 2015, and we started mostly with just big abdominal procedures. One of the things I talked briefly about was, you know, how thoracic epidurals are gold standard, but even at UCSD, just as recent as 2015, those thoracic epidurals were placed in the operating room by various providers. They were never tested, and then these patients, you know, had all sorts of infusions, again, very provider dependent, written for them, and then we'd go follow these patients post-operatively. Some of these epidural catheters were placed so low that the patients were not ambulating. Some of them were not in the epidural space at all. And some of them were, you know, the infusions were not optimized as their blood pressure tolerated. And then on the other side, you know, then you had the surgeons who were very frustrated because their patients are still in pain. They get phone calls in the middle of the night that the patient's pain is not controlled. So then you get an intern who's, you know, writing them for huge amounts of opioids. And the Foleys, they were staying in for a long time because the patients had an epidural. Even if it wasn't working, we were still keeping their Foleys in. So the acute pain service started just kind of as a whole package, which is what we talked a lot about in this talk, this multimodal analgesia. We start with preemptive analgesia in the pre-op. We meet our patients, we discuss a pain management plan with the surgical team. We give some gabapentinoids, we apply a scopolamine patch, we give acetaminophen, and then we place the epidural in the pre-op area. We give, like I talked to you guys about earlier, a pretty generous test dose. We make sure that the patient has a level, otherwise that epidural comes out before they go to the operating room. And then intra-op, we recommend minimizing opioids. Occasionally we'll give a dose of Duromorph in the epidural. We do give Decadron and sometimes some ketamine. The epidural is bolused right before wake up because a lot of these patients have hemodynamic changes intra-op. And then post-operative period, the acute pain service manages not only the epidural, but also all of their opioid prescriptions and applies this multimodal opioid-sparing phenomenon. So we also, you know, continue the acetaminophen and lidocaine patch. But more importantly, we encourage these patients to get out of bed. We pull their Foley catheters as soon as they're able to ambulate. We transition them to an oral regimen once they're able to tolerate, to advance their diet to a full liquid diet. And we've had great outcomes For HIPEC procedures, their opioid requirements prior to APS versus post-APS was decreased by nearly 50%. Patients who are having Whipple procedures also had similar results where their opioid requirement went down to 50 or 60 or 60 some percent. But even more exciting than that is that the patients with the Whipple procedure where they were going home sooner, about 2 days sooner. So we were very excited about that. And they're getting out of bed sooner, they're eating sooner. So APS was associated with a decrease in time to ambulation and tolerance of oral diet. And also in some of our studies when we looked, ileus occurred much less, was less prolonged in the APS group. Sorry, 1 second. I'm gonna hand it back over to Dr. Gabriel.
All right, so we wanted to put it all together. You know, we talked about multimodal analgesia, opioids, epidurals, acute pain service. And then now there's this concept that's been popularized throughout the world of enhanced recovery after surgery. A lot of components to it, not just pain management. You know, the fluid management is important, patient education, nutrition, a lot of different things. Hold on 1 second. Let's get that. So it's essentially it's a shotgun approach of everything theoretically good packaged into one team protocol. The problem is when we do things like this, it's really hard to tease out which is actually helping. And so, you know, you end up doing everything, but using way more resources. You potentially are using way more resources than you need to because you don't know which ones to get rid of or which ones you don't need to focus resources in because it's basically a one package deal. Why it's good? You know, some parts of it has better evidence than others. Some of them have, some of the things people do in the ERAS protocols don't have any evidence, and some have really great evidence. And, you know, we talked about a lot of the different things that have shown great evidence and not. But it does enforce a team-based and a patient-focused approach. And when anything is team-based or, you know, patient-focused, for it to be done right, requires a lot of organization and collaboration and everyone on the same team. Now, if that doesn't happen, then like with anything, you know, it may not even work and people may abandon the idea. And if it does work, people will continue to do it. Some studies have shown improved outcomes, some shown no improved outcomes. I just want to give a few examples of some papers that were published in the last few years where they actually succeeded implementing enhanced recovery protocols. One in Uganda for C-sections. They did a number, I'm not going to read off everything here, but their ERAS protocol consisted of a number of preoperative checkpoints, intraoperative, some analgesic protocols, and then some postoperative care. And what they found was they were able to decrease length of stay and improve and have improvement in their pain control. Another study looked at hip fractures and colorectal surgery, published in JAMA Surgery. They again had a protocol for both of these types of surgery. And these graphs are basically showing the ERAS versus non-ERAS group. And in summary, they showed that there was an improvement in ambulation, improvement in nutrition, decrease in opioid use, decreased hospital length of stay, and more patients were able to be discharged home versus a skilled nursing facility.
Sorry, guys, I couldn't unmute. Oops.
Wait.
Sorry, we're having technical difficulties. Just our conclusion was like Dr. Gabriel touched on, there's no one right answer. There's no one protocol, one process that will work. I think it's very patient, surgery procedure, and institutional based, and your resources that are available that you can really go from there. There's no opioids are bad or opioids are good. I think if we always just try to meet in the middle, we'll have great success.
Thank you, Dr. Saeed and Dr. Gabriel, for the excellent presentation. I'd like to open it up to the floor for questions.
Hi, this is Stu Foreman. I just want to thank both of you for wading into the very murky space that you just discussed in excruciating detail. I tend to agree that you know, we have a lot of enthusiasm for ERAS protocols among our anesthesiologists here at MGH, and I think while I agree that some of the benefit from, say, the pharmacological interventions is very limited, and the theory is unproven, but the key benefit, and I think you guys both are sort of alluded to this, is that it gets the anesthesia team talking with the surgeons and talking with the nurses and focusing on the patient instead of on, you know, the usual care. And so it in particular, it's an educational opportunity to introduce many of the surgeons to some of the literature that they're often unaware of about how to best manage post-operative pain. And I think you know, the other point that comes up, and I tend to agree, is that most of the research shows zero impact on what we do intraoperatively on, say, long-term opiate utilization. There's a population of patients who will, if given the opportunity and the prescription, will do that, and then many others will not. So it really is a cultural issue in my mind, rather than a purely medical issue. And I'll just stop there.
Thank you.
Are there any other questions? All right. Thank you, Dr. Saeed. Thank you, Dr. Gabriel. Once again, excellent talk. We'll see you guys soon. All right. So at this point now, we'll move on to our session number 2, which Dr. Leslie alluded to. This is entitled Strategies to Avoid Postoperative Delirium. I'd like to introduce first Dr. Liz Everett, who's going to give a talk entitled Perioperative Strategies to Prevent Postoperative Delirium. Dr. Everett is an associate professor of neuroscience at Cornell Medicine. She's the scientific head of research in the Department of Anesthesia and Acute Pain Medicine at St. Vincent's Hospital, Melbourne, and an associate professor at the University of Melbourne. She has over 60 publications in cognitive clinical research. She's an associate